Welcome to everyone. Today's session is called the Primary Care Network, Tackling Social Determinants of Health, the launch of Deep End Canada. My name is Archana Gupta. I am a family physician and a researcher based at St. Michael's Hospital, Unity Health Toronto, and a scientist at Upstream Lab. My area of research is the integration of primary care and public health, which promotes health equity, particularly for vulnerable populations. And I also believe strongly in using participatory action research approaches in my work. We're going to begin with a land acknowledgement, after which we'll talk about objectives and introduce our speakers and then begin. We acknowledge that Indigenous peoples are the traditional guardians of this land that we call Canada, in which many of us gather, and that many of us are joining from diverse treaty and unceded territories. We will take a moment to acknowledge the land where Upstream Lab is located, known as Toronto or Toronto. Over many centuries, Toronto has been home to many nations, including the Anishinaabe, the Chippewa, the Haudenosaunee, the Huron-Wendat, and Mississaugas of the Credit. Toronto is covered by the Toronto Purchase Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is also a territory covered by the Dish with One Spoon Wampum Belt Convention, which is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Toronto is now home to a vast diversity of First Nations, Inuit, Métis, and Indigenous people from across Turtle Island who enrich this city. In our work at Upstream Lab, we are committed to embedding calls to action from the Truth and Reconciliation Commission of Canada to advance the sovereign rights of Indigenous people across Toronto Island. Colonialism is an ongoing process that impacts many of us in different ways. As health professionals and providers, we are uniquely situated and privileged to advocate for decolonization, health equity, and to help address the many social needs of our communities. Today, we hope to highlight how health professionals can work with community members to address the many social and structural factors that determine our health. From this land acknowledgement, we would also like to take a moment to highlight the integral role patient partners and those with lived experience have played in the development of Deep End Canada. We want to apologize with humility that today's session does not include insights from our patient partners, and we will correct this in future sessions. Today's session will focus on the role of primary care and primary care networks in addressing the social and structural determinants of health. It will provide insights from the GPs of the Deep End project and highlight successful strategies from Scotland and other countries for improving patient and community health through the Deep End. The goals of Deep End Canada and how you can get involved or learn more. So without further ado, I would like to introduce our speakers.
Yes, thanks. I'm Graham Watt. I'm a retired professor of general practice, you'd call it family medicine, at the University of Glasgow in Scotland. I am the founder of the Scottish Deep End Project. I edit a newsletter called the Deep End International Bulletin. The most important thing I ever did in my career was to work with a man called Julian Tudor Hart, a pioneering GP in South Wales, inventor of the inverse care law. And the Deep End Project is in many ways a continuation of his example and values in primary care.
Hello, everyone. I'm delighted to be a part of this panel discussion today. I'm a pharmacist and assistant professor at Memorial University School of Pharmacy. I'm so excited to see so many Newfoundlanders and Labradorians join the discussion today. Thank you, everyone. So folks, I am currently working with the Upstream Lab to actually implement their Spark tool, which I'll talk a little bit about later on, in community pharmacies in this province. And so I'm delighted to bring the pharmacy lens to this discussion and to answer any questions that you folks may have about the role of the pharmacist in screening for the social determinants of health.
Hi, Tante, bonjour. Bienvenue à tout le monde qui est francophone sur l'appel aujourd'hui. I am Ginetta Salvalaggio. I am a settler of European origin, Franco-Italian, here in Amisquachiwaskahigan, which is Beaver Hills House, the original name for Edmonton, here on Treaty 6 territory. I am still a family physician in Alberta. I'm also a participatory health researcher and professor at the U of A, and I work with and for structurally vulnerable people who use drugs primarily, and I'm happy to join the call and talk about how we can advocate and be inclusive in that. Thanks.
I am a postdoctoral fellow. I work at the Upstream Lab. I live in Montreal, so I'm not in Toronto. So I'm on unceded territories of the Ganyan-Gehaga or Mohawk communities. And my specialization, I guess, in my research is scaling up primary care innovations and how we can think about how we implement them on a wider scale. So I do research, and the other hat I wear is an implementation support specialist or QI coach. So I do a lot of hands-on stuff with primary care practices here in Quebec. So bienvenue aux Québécois aussi.
Thank you so much. And we're so excited to have all of you here today. My first question is to Dr. Watt. Could you share the history of GPs at the Deep End Network in Scotland and how it has inspired networks globally?
I'll try and do so briefly. Thanks, first of all, for the pleasure of sharing our experience with you. The Scottish Deep End project is 15 years old, and there are 16 other projects now in Ireland, England, Wales, Denmark, Australia, and Japan. Great to have Canada coming on board. That's the 18th project. There's actually a 19th brewing as well. And whatever you say about the Deep End projects, they are definitely catching and responding to an intrinsic feature of many health systems. For catch-up on the University of Glasgow website, there are 3 things you can access. One is a whole lot of reports from the Scottish project based on roundtable discussions with frontline practitioners who are the only people who know what's happening locally, knowing the patients and the places. That knowledge is not available in academic centres and has to be contacted. There are 10 international bulletins recording what all the various projects have been doing, if you're interested. And there's also video presentations from a Glasgow conference just 2 months ago, the second International Deep End Conference. Most health systems like to think of themselves as level playing fields, but a better analogy is a swimming pool, where everybody who can be seen has their head above water, but people working in the shallow end have their feet on the bottom, and people in the deep end are treading water to stay alive. And that metaphor has rang a bell with many deep end practitioners and features in the logos of every project. There are 4 features to starting. The most essential is engaging with frontline practitioners, without which not very much else will happen. There needs to be some kind of central coordination from whatever vantage points available, and they vary. You need activities to keep enthusiasm going, whether it's to do with individual career development, education, research, or advocacy. And you need communication, which is evident today, to share that information and learning. All of the projects are different. They're different in size, in the people, in their geography, their history, their opportunities, their constraints. Canada will have particular challenges and I guess advantages. But they're all similar in the sense that they're an expression of shared values and aspirations, which we sometimes characterize as by counteracting processes of exclusion, which are ubiquitous. By doing that, inclusive healthcare is a civilizing force in an increasingly uncertain, fragmented, and dangerous world. What the Deep End project has given to participants is identity, voice, profile, shared activity, shared learning, and impact to previously neglected and often isolated groups of frontline practitioners and the communities they serve. Connection is a key part of the Deep End movement, leading to 2 types of solidarity. There's defensive solidarity, like circling the wagons against hostile forces, which can be characterized as an act of resistance, which is in some places a first step. But there's also transformational solidarity in which people are working together to affect change, including system change as well as in their workplace. We like the quote from Margaret Mead, never think that a small group of committed individuals can't change the world. Indeed, it's the only thing that ever has. There's a very good book just out now called Solidarity, the Past, Present and Future of a World-Changing Idea by Taylor and Hunt Hendricks. And they describe organizing as a kind of alchemy that turns alienation into connection, despair into dedication, oppression into strength. And this is what's before us as now an international movement. Canada will be our ninth country and fourth continent, and it continues to spread. So in conclusion, to Deep End Canada, I would say welcome on board, and we look forward to learning from you.
Thank you so much, Graham, for that introduction and the history of what's happened and what's happening globally. I'm going to pass the next question over to Janetta. Could you highlight the movement that is happening in the Alberta context and the role of community engagement, health justice, collective organizing, and advocacy within and around primary health care?
Thanks very much. I did situate myself a little bit earlier, but I also want to just, one thing that I thought would be very helpful to kind of premise what I have to say, and I think builds on what Graham had to say, was there's a lovely Nehiyaw word that has been shared with me through community members and knowledge keepers here. And some of you may be familiar with this term, but it is Wichitawin. And it's actually, there are very similar constructs in other Turtle Island languages, but Wichitawin, as I understand it, and I'm not a native Nehiyaw speaker, but it means mutual aid. It's rooted in other words for love and empathy and kindness. And this mutuality is extended to people, but also to the land and all that exists on the land and in it. And so I just want to think about Wichitawin and how we are all connected, because we are talking about collective care. We are talking about solidarity here this morning. So just, if I could just ground us in that. I would also situate myself that my training actually was rural. I'm rural trained. I was in Northwestern Ontario for that and did some locums in rural spaces. I was just interested very much in community and community spirit and what people can do outside of the confines of large, well-resourced towers and structures. And that's morphed for me for a variety of reasons into working in a very urban setting, but and many people talk about street medicine, but working very much with the urban underserved and thinking about how actually innovation occurs within both spaces when you're faced with constraint, and we certainly are as a society. We're really in polycrisis right now, aren't we? We certainly have a primary care crisis. We've just come out of the most profound pandemic in a century. We've in Western Canada, speaking to the Alberta piece, we're also reeling in a drug poisoning crisis, as I know many of us on this call are. We are experiencing discomfort societally, broadly, and we have a very hard time as humans making sense of that discomfort, processing it, healing from it. And a lot of times we would rather just go away. So I encourage people to kind of lean into that discomfort and think about within that space, how can we be innovative? How can we be creative? I think Alberta is a hotbed of creators and innovators. My favorite example of this is in the mid-2000s when I just got back to town after residency, and I was just trying to find my footing back on my own home turf. How we actually started exploring putting naloxone in the hands of community for the first time. And we had kind of imported this out from some innovators in the harm reduction space in Chicago. And it's a little known fact that in central Edmonton was the first time we started out handing out naloxone. And I can't say that physicians led, but physicians needed to be there, and primary care professionals needed to be there and at the table to make it happen, to lend our privilege to actually getting the prescriptions going and that kind of stuff. It was community led, and I love that story because the innovation has always come from community, but it absolutely needs people at the table to ally and to show up. I think we keep innovating. We keep innovating despite what many people might feel is tremendous odds. But we I think those of us who are intuitively interested in this work, we recognize that there's a wheel of power and privilege, and I find myself close to the center of that wheel of power and privilege, but working outside of clinic walls and becoming situationally aware and working with community, it compels me to think about the margins. It compels me to think about the beauty that happens when you take a participatory lens and you take an inclusive lens and you start designing your systems of care outside of the center of that wheel of power. And it turns out that and we know this from reams of work in the design world and in complex systems, is that when you start paying attention to those margin inputs, when you start paying attention to the outliers and the people who aren't in the middle of your normal distribution, which is seldom normal, you start designing better for everyone. So the minute that the outliers are paid attention to, everybody benefits. And I think that's really important. And I think that's something that as healthcare professionals, we can highlight for people that this matters and everyone is going to benefit. Everyone comes along for the ride. So, I mean, my parting thoughts would be to show up, to ally, get yourself out of the clinic, out of our comfort zones, pay attention to a variety of data, not just what is being fed top down, but start paying attention to what really matters. Ask the people that we see in community what really matters to them and what stories need to be told. And that's where any advocacy should be centered. I'm going to leave you with a quote that came from an ancient piece of research I did quite a while ago, entitled Rethinking the Messenger. And I love this metaphor. People from community told me, we need a vehicle, you know. And a physician colleague of mine said, you can borrow my car. So I asked, what's the vehicle? How do we do it? So the community member said, a person can get us in that door, get us noticed. Seriously, they can. You noticed us. He notices us. She notices us. And like you guys are doing something about it, but we need that next step. A healthcare professional can inadvertently direct us in a direction. I don't have to borrow the car, but he can tell me if there's a car down the street from you. The keys are in it, the engine's running, lots of gas. So I just want you to think about, perhaps it's not our role to drive the car, but it's our role to provide the resources for someone else to do the driving. Thank you.
Thank you so much, Janetta. I think that you very much highlighted the important role of the Deep End Canada in the opportunity to share stories, to share innovations, and learning from different contexts and how that can be applied in different communities, and also the approach that's been taken in your work. So thank you so much. I am going to pass on the next question to Tiffany. Can you share with us how pharmacists and community pharmacies are working to address the social determinants of health in your context, and how primary care teams, ancillary providers, and community organizations outside of primary care can work together to address the social determinants of health?
Thank you, Archana. Certainly, I can speak to those questions that you posed, but before I do that, I hope I can just take a moment to kind of reflect on what others have said here today and kind of link it to the questions that you've asked me specifically. So folks, I hope that it's become quite evident to you as you listen to Graham and Janetta speak that the primary care, or sorry, the Deep End Network Canada really has a focus on thinking about how all health and social care systems can work together. And, you know, our vision is that we think about not just primary care providers working in a clinic, but how we think more broadly about how primary healthcare is assembled and all of the groups that play a role in delivering primary healthcare services. And of course, that includes our partners in communities and the important role that community-based, not-for-profit organizations play in providing health and social care services to individuals and families. And so I certainly want to acknowledge the role that those community-based organizations play. And thinking about community pharmacists, so now to kind of get onto the questions. So community pharmacies and pharmacists have an important role to play. And, you know, if we think about community pharmacies themselves, they're often part of an individual's social and community network. And so we know that social community networks are one of the social determinants of health. And so in many areas, you know, particularly in remote and rural areas, but also in some pockets in urban centers, community pharmacies serve as gathering spaces for new and old friends to catch up, I like to say, and to talk about life events, what's growing in their garden this year, or even here in Newfoundland, a popular topic, of course, is the weather. So these community spaces are really important to ensuring that we can tackle the social determinants of health in a meaningful way. And, you know, community pharmacies in some areas may be, in fact, the only social space within a small community. So it makes the community pharmacy an essential social structure within that community. And then when we think about community pharmacists, and this is, of course, a topic that I'm very, very interested in, you know, those pharmacists, especially those working in rural and remote communities, they tend to have long-standing relationships with their patients, and patients share a lot of personal information with their pharmacists. They look to their pharmacists for information about resources, as Janetta spoke about. You know, we serve as the car that connects people with resources in their community. And so the most common and perhaps well-known example relates to financial support for medication coverage, of course. You know, as an individual's employment status changes or their financial situation fluctuates. This is really common nowadays, right? With the rising cost of living and associated financial precarity that we find ourselves in. Pharmacists do engage in connecting these individuals with compassionate access drug programs, supporting them to fill out, you know, the appropriate paperwork to apply for government-funded medication coverage services. But there are many other roles that perhaps are not as well known, not recognized or not talked about publicly that pharmacists actually take on in this space. So this includes, you know, connecting patients with social networks and community-based organizations. These might include organizations that provide support for individuals who are transgendered, for example, or those who may be experiencing intimate partner violence. So pharmacists really do have this trusting relationship with their patients. They care about their patients' well-being and social health. They get to know their patients very well. And so this has been happening, you know, historically for a very long time, but we didn't really have a language or a label to attach to this role. And now, thankfully, this role has been recognized, and we see that the role is now acknowledged in documents, for example, that define the standards of pharmacy practice, and also the Canadian pharmacy educational outcomes. We see this role talked about in those documents. So I'm very passionate and feel so blessed to have met the folks at the Upstream Lab. connect on these issues and to have this great access to this great network of professionals who are interested in tackling the social determinants of health and providing supports to individuals, families, and communities. So I want to now, of course, link this to the pharmacist role. So I'm leading a project here in Newfoundland and Labrador that will actually study the implementation of the SPARK tool in community pharmacies. So those of you who may not be familiar with the SPARK tool, it was actually developed and validated by the Upstream Lab. So the Upstream Lab has done all this fabulous work to create this tool. And it's intended to assist primary healthcare providers with collecting information from their patients about the social determinants of health such that they can provide supports. Because of course, if we don't know about the challenges that folks are experiencing, we're not able to provide assistance. So to my knowledge, this will be the first study of its kind in Canada, and it really is a novel application of the SPARK tool in the community setting. There is some work being done in this area in the United States, so it's not completely brand new, but like I said, it will be the first application in Canada. And so what we hope is that lessons from this work may inform more large-scale implementation of the SPARK tool in community pharmacies. And I'm really delighted, to have the support of several professional and health policy organizations here in the province, including the Newfoundland and Labrador Pharmacy Board, the Newfoundland and Labrador Centre for Applied Health Research, and also the Deputy Minister of Health Transformation with the Department of Health and Community Services here in the province. So hopefully, Archana, that captures sort of your first question that you posed to me. I think I'll take a moment to just talk a little bit more in depth to answer your second question, if that's okay. So folks, it's important to acknowledge that involving any one health professional group is just one tool. And it's a tool in our toolbox, but together we can all make a huge impact. And so it's important to acknowledge that. All of our health and social care systems need to work together, of course, in order to effectively address the social determinants of health in a meaningful way. And as I mentioned in the beginning, these not-for-profit community-based organizations that provide the social support to individuals and families, they're really the true heroes in this space. And we could not do our work and refer, our patients and individuals without their support. So I think it's important for us as a group to acknowledge their contributions. And, to think about team-based primary care providers, ancillary primary care providers, those that work outside of the clinic setting, the Deep End organization is bringing all of those groups together. And that's why I think this project or this coalition, whatever you want to call it, is going to have such a profound impact on health and well-being of individuals. Each and every one of us as healthcare professionals have an important role to play. And I think other speakers have used those quotes to demonstrate that. And so I'll just conclude today with saying, no one professional group can address the social determinants of health alone. We need to develop, this work of this coalition will help us develop a health and social care strategy that leverages the knowledge, skills, and geographic location of each provider. And, I really am a firm believer, and it informs all of the work that I do, that we can have a positive impact when we all work together. And so that's why I feel so much pride in being here today. And so I guess I'll end with that. Thank you, Archana.
Thank you so much, Tiffany, for sharing that rich information about the role of collecting socio-demographic information in different contexts and the roles that different healthcare professionals play in supporting our patients with social needs. And we're going to come back to this idea about how socio-demographic information can be used as we continue this discussion. Next, I'd like to turn it over to Melanie Ann. And Melanie, I'd like to ask you, Tell us about what's being done in the Canadian context in primary care to address social needs, and what are the goals of Deep End Canada?
Thank you. Thank you, Archana, and thank you to all the other speakers who've kind of really highlighted why we're bringing a group of people who share these values of Deep End Canada together. And kind of to come back to the deep end metaphor that Graham introduced at the beginning, what we know in Canada right now is that the deep end is not only getting deeper, but it's growing, it's taking over the shallow end. We know that health inequities are growing, both in primary care, but across our country, with kind of economic hardships, and those inequities are growing. And so it feels even more pressing now to be launching Deep End Canada. And as Tiffany mentioned, this is work that has stemmed out of about a decade of work that's been done at the Upstream Lab in terms of thinking about how we can collect information from patients to really know what their social needs are, and that we can start to build rigorous and robust evidence that helps us advocate for change, for policy change, for programs to adapt both individual care, lead quality improvement projects at the clinic level, but also kind of advocate on a larger scale. And that's really the goal of Deep End Canada, is to bring people doing this on smaller scales. You've heard about pockets of innovation led by Tiffany, led by Janetta. And there's tons of small kind of projects that are being piloted across the country. And we really see this movement towards tackling the social determinants of health in primary care and beyond growing across the country, but they remain small pockets of innovation. So Deep End Canada, really the goal is to bring these people together that are champions and leaders and who are thinking about bringing these concepts into primary care to really tackle inequities, and saying, how do we learn from each other? How can we inspire each other? How can we support each other? And how can we share the tools that we're developing so that we give ourselves kind of the best arguments and the best evidence, so that we can then really do a better job together of advocating for the changes that need to be made, whether that's from a research perspective, health professional perspective, a community perspective, but really kind of bringing all of these voices together to advocate for the same thing. Just to show you kind of en primeur, as we say in French, the Deep End logo, which was adapted from the Glasgow logo and other logos that have been adapted across the world to make it Canadian. So primary care at the deep end, soins primaires en milieu défavorisé, which is a little bit less poetic in French, but does capture kind of this idea that we're trying to bring together those who work in spaces that offer kind of frontline services to populations who are facing inequities and structural discrimination, or different kind of experience different social needs across the country. Our mission is to advocate for the collection and use of social determinants of health data. So as I mentioned, we do have kind of a tool that's been developed from the Upstream Lab that we can share. We have materials. We've piloted this across 5 provinces, and we will be sharing kind of those early lessons that we've gathered, and different materials that we've put together in terms of training, if that can help any kind of practices or organizations that are interested in collecting this data. And really the main goal is to address health inequities in primary care. And when we say primary care, we say very broadly, we include primary health care, we include community pharmacies, or anybody who kind of feels that they can contribute to this mission, to this vision of tackling inequities in a healthcare space and beyond, are welcome to join. You can visit our website, which was just launched today and will be evolving over the next few weeks and months. And if you're interested in how you can contribute to Deep End Canada, please contact us. You'll find more information on the website, but please reach out. The idea of how we are going to do this is going to be very kind of evolving depending on those who are joining and how they want to contribute, how they want to be involved. Graham kind of mentioned some magical ingredients that make Deep End networks work. And so we will do our best to implement those in Canada. We have planned so far to have some facilitated meetings to facilitate sharing and learning of different innovations across the country, sharing those kind of tools and resources and evidence that we've gathered so far. We have funding. We're very fortunate to have funding for the next few years from the Canadian Primary Care Research Network, and this work has also been supported by the Canadian Institute for Health Research and the University of Toronto, the MAP Centre for Urban Health Solutions, and the DFCM. And so we will also have kind of coaching and implementation support that will be available for practices who want to implement innovations or kind of start collecting this data across the country.
Thank you so much to all of our participants for joining today. Thank you so much to all of our speakers for sharing your insights and your thoughts. We were really grateful for your time. I hope everyone has a wonderful rest of their day.